Brad Elmer again. Now I'm going to go over anti-infectives. So, historically, this has been a harder test for people to kind of understand, same as cardiac. I don't know how you guys did in cardiac. But for anti-infectives, the problem is there are a lot of different classifications. There's also a lot of different fluff information that you don't really need to know, but it's more pertinent if you're, say, a pharmacist. And the nursing, for anti-infectives, isn't focus on the nursing interventions, things you need to assess for, kind of narrow things down and ignore the stuff that's just not really important. So, for instance, like gram-negative, gram-positive. So all you really need to know is gram-positive is generally going to be on your skin, and gram-negative is mainly going to be colonizing your GI tract. So if anyone has some abdominal surgeries, colostomy, something like that, they will give them some sort of polycefapine, something, gram-negative medication to kind of help prevent any problems. You don't really need to know, I'm going to, little asterisk there, they really know what treats gram-negative, gram-positive. They shouldn't test you on that, because that's not technically what you're being tested for. You're getting tested on nursing knowledge, not high-level pharmacology. So the other thing is bactericidal, bacteriostatic. What you need to know is what the concepts mean, not so much which medications are which ones. So you need to know that bactericidal actually causes cellular death of the bacteria. Bacteriostatic merely kind of inhibits its growth and makes it easier for your body's own immune system to take out the bacteria. Then you have broad spectrum versus narrow spectrum. Broad spectrum is going to be used in like the hospital setting or in the clinic when you don't really know what the infection is. So you have a broad spectrum. It's going to affect a lot of variety of different bacteria. The problem with broad spectrum is it's not really specialized. This is where you get into the case of drug-resistant bacteria, because the same antibiotics that are broad spectrum have been used continuously over and over again. The bacteria will generally gain a resistance to that medication because no one completes their course of medications. That's going to be a huge teaching point, is ensuring like which one of these patients needs some education, or which one understood the education. Is going to be, I'm going to take my entire course of antibiotics. That's going to be a huge key factor for this test, knowing that. Other thing is going to be narrow spectrum. So narrow spectrum is usually done after they've drawn cultures. They know, okay, you are infective with A and B. So A and B are very susceptible to antibiotic Z and Y. And so it's only going to be targeting those specific bacteria. The other problem with broad spectrum is you have a lot higher chance of side effects. And by side effects, I mean a secondary super infection, as it's called in your notes. So basically a super infection is when you are, because your body is full of bacteria everywhere. It's while your GI tract works is bacteria. And then also in your mouth. That's how you kind of help get things going. But they're not harmful for you in the homeostatic path that they're in. But when you think of a broad spectrum bacteria, what you can do is you can inhibit certain bacteria, and then other bacteria will just grow exponentially, causing a secondary infection, such as thrush in the mouth, which is the basically the white yeasty stuff in your mouth, or C. diff. C. diff's the other big one, because you screw up the bacteria in your GI tract. It's going to cause diarrhea, because usually that bacteria kind of helps block things up. It's not there. The C. diff, which can be colonized in someone's colon, will just flourish, and then they'll have the telltale signs of C. diff, smelling poop and whatnot. You can also lead to upper respiratory infections, because bacteria can be colonized from your mouth down to your throat. So basically what you need to know is broad spectrum antibiotics are going to have a higher chance of causing a secondary infection or a super infection. Alright. Let's see here. just so I kind of already touched on it, but just in case I didn't enough, resistant organisms are predominantly from overuse of antibiotics, especially in cases of children, because the common cold is rhinovirus, not a bacteria, but people will take their kids to the clinic to get antibiotics, so they prescribe penicillin. Well, a lot of things have been used against penicillin, but then they see, okay, little Johnny's feeling better, and I give him an antibiotic, and so then what's kind of left in their system is all the bacteria that were resistant to the penicillin. Well, then they grow and flourish and so on and so forth, and it continues. The other thing is just kind of like I kind of said, is that the people don't finish their entire course of antibiotics. So that's where drug resistance comes from. Other thing to be aware of is all your side effects. So nausea, vomiting, diarrhea, every antibiotic in the world, don't worry about it. Warfarin does not play well with anything. So warfarin, drug interaction is what it is. Oral contraceptives, if they affect probably through the hormones, I'm not entirely sure. But they affect the estrogen levels in the female body. Thus, oral contraceptives do not work well when you're on antibiotics. So it's another teaching point for any women of childbearing age. Be aware of that. The other thing to kind of be aware of is if it's given IV, a lot of antibiotics can have phlebitis and just are really bad on your veins, so be aware of that. So the drug classes. First one is penicillins. So penicillins is kind of like the one you probably made it in your like 5th grade science class. You can grow it on oranges. Basically, it's penicillin, it's mold. The thing though with penicillin is large amount of allergic reactions from it. So you always have to assess your allergies for any case. The other thing is a cross sensitivity between penicillins and cephalosporins. So if you're allergic to one, you're allergic to the other. The other big thing is a lot of bacteria now are becoming resistant to penicillin. So there's this regular penicillin G, which is a general broad spectrum antibiotic. But then you also have 2 different types of drug resistant bacteria. Penicillinase, and now it's also beta-lactamase. So what penicillinase and beta-lactamase, what they are is they are enzymes on the cellular wall or cell membrane of the bacteria that kind of degrade the antibiotics from being effective. So there are new penicillins that are resistant to these. So amoxicillin or augmentin, these are resistant to your penicillinase bacteria, so bacteria that have penicillinase enzyme. Other ones are the beta-lactamase resistant penicillins, and those are methicillin and nafcillin. These are also used as a drug of choice for MRSA. I have it highlighted in my notes. I'm going to highlight that now. Generally speaking, the drug interactions for penicillin are going to be hypernatremia and hyperkalemia. This has nothing to do with the actual medication itself. It's usually what's in the inert ingredients in the pill or in the solution. Like the penicillin itself doesn't cause hypernatremia, hyperkalemia. It's the other compounds found in the antibiotic that are high in sodium and high in potassium. So kind of be aware of that. Also be aware that penicillins do not work well with aminoglycosides, so kind of just those drug interactions between those 2 classes. Okay. Next one is cephalosporins. Cephalosporins, again, huge chance of allergic reactions, and also if you're allergic to penicillins, you're allergic to cephalosporins. You're kind of like the same class, yet different. So the other thing to be aware of with your cephalosporins is there's several generations as they go on. The first generation is cephalexin, and the later generations are rocephin and then cefepime. So as they go on the different generations, what happens is they, one, have a longer duration, so you can use it less. They become more resistant to beta-lactamase enzyme, and they can also cross the blood-brain barrier into the CSF, into the brain for any sort of brain or meningeal bacterial infections. Random side note, I had a patient the other day who had a brain infection because he got shot in the brain and they could not get the bullet out. So basically, he had his brain just kind of hanging out in the air for like weeks. So he couldn't do anything with it. He's fine now, but just a random note of you never know what you're going to see. Whether these are like, why do you know someone's going to need a medication to cross the blood-brain barrier? Well, your patient may have gotten shot in the head. So there's that. Anywho, back on topic. So the only thing with your cephalosporins for education, it's predominantly going to be no alcohol, kidney functions, kind of aware of that. At the end, I will go over which medications can lead to ototoxicity, which ones you should not give alcohol with. So I'll kind of give you like a good rundown of some of the generic side effects for all of them at the once. Alright. So the next medication is carbapenems. Carbapenems are a really kind of old school medication that aren't used predominantly well unless as if they find out, okay, this bacteria is susceptible to this, nothing else will work, let's use it. The problem is it's going to be more for your very serious life-threatening pneumonias and your UTIs. The problem with it is it can build up in your system because it's not getting excreted well, and it can lead to seizure activity. It can also lead to GI complications, of course, they all do. But it's excreted renally, and it's also very toxic on your kidneys, so be aware of acute kidney failure. But the main thing with these are going to be seizure activity, and the main one you're probably going to see is meropenem or the pyraxmin. I'm not very good at pronouncing these. Before I go on, I forgot something in the beginning, general overview of pharm for anti-infectives, and that is blood cultures. So before you give any antibiotic, you have to draw blood cultures. Predominantly, I don't know what you were taught in class, but you're going to want to draw 2 sets of cultures from different sites. So be it a peripheral stick in the arm and then a central line from their subclavian or whatever. Usually it's 2 different samples from 2 different sites. And those are then left alone. There's an anaerobic and aerobic vial to kind of help figure out what the infections are. So there might be a question about someone drawing, like when do you draw cultures? It's going to be before you give antibiotics. And if you give them afterward, you can still do it, but it has you could screw up the chance of what's going to grow is appropriately growing. Sorry, I missed that earlier. Alright, so the next antibiotic is vancomycin. Vancomycin is very unique in that you have to give it orally or IV for different things. It does not cross through the GI tract. So if you give oral vancomycin, it'll just stay in the GI tract, and this is going to be used for C. diff. So it's going to stay in your colon and through the GI tract, go through and treat the C. difficile infection in the colon. Now, if you give it IV, then it'll stay in the bloodstream and work any sort of septic process they're having that way, especially for MRSA. It's a good one for MRSA. So Vanco IV MRSA, Vanco PO C. diff does not cross through the GI tract or from the blood to the GI. Things to be aware of, it can lead to ototoxicity with prolonged use. The main one you're going to see is what's called red man syndrome. Red man syndrome basically just causes histamine response, basically causes extreme vasodilation. So of course you can blush out, and it's going to be systemic vasodilation. And remember, from cardiac vasodilation leads to hypotension, so that's going to be your main concern with this. Is going to be red man syndrome, extreme dilation, hypotension. So you can pre-treat for this by 1, giving it slowly when you give it IV, and then you're going to want, if you're going to be using this for a long term, so you're going to want to get Vanco levels continuously, peaks and troughs, which you probably kind of covered in the first couple classes. And you can also pre-treat with antihistamines. Alright. That's vancomycin. Next, we have tetracycline. Tetracycline, or the next one is doxycycline. These ones you can all kind of focus on. They all end in cycline. This one is predominantly used for nowadays topically for acne treatments because it's going to treat bacteria with a mycoplasma barrier. So basically, if you don't know what that means, think back to biochem, where you had the cell membrane, then it had a separate outer membrane, which is mycoplasma. It's like thick mucus, so it's hard for things to get into it. So this works predominantly well in those mycoplasm infections, which usually is cases for acne, and then also for chlamydia. So if your patient had STDs or a history of that, this is going to work for them. It's not very used orally for systemic infections, but it is used, like I said, for acne. But you do need to know drug interactions for antacids, calcium, magnesium. So basically what that means is it's going to bind those substances and not have any effect. So if they have any sort of multivitamin around the time they're taking this, it's just going to bind to the calcium, magnesium, and it's going to be created out and not really have an effect. The other thing to be aware of is going to have huge effect of hepatotoxicity, liver failure. Be aware of your signs of liver failure. And then the other main one, which I can probably almost guarantee is going to be a question somewhere in ATI or in your class. It's one of those odds I would like to ask, is that you do not give it to anyone under the age of 8. It's going to cause teeth discoloration, or eventually kind of basically what it is it's decaying and eroding the teeth down to nothing. Also, it can lead to esophageal ulceration. What that means is heartburn. It can lead to gastric acid being shot up in the esophagus, causing ulceration. So be aware if they have any previous signs of alcohol abuse, because people with alcohol abuse are more prone to esophageal erosion, or anyone with some sort of GERD. And anything that causes heartburn or GERD, per NCLEX Perfect World, is you have them sit up for 30 minutes after administration. It's kind of like 30 minutes after, they should be fine afterwards, per NCLEX. The next one is going to be the macrolides. Macrolides is erythromycin. This one is a good kind of general broad spectrum. It's going to be the drug of choice for people who are allergic to your penicillin and your cephalosporins. The problem, this is what usually is called your Z-Pack, if you've ever gone to the clinic, Zithromax. It's used predominantly more in like your urgent care settings like that, because it has an increased compliance with it, because it's only a 5-day course versus the usual 10-day course of antibiotics. Side effect wise, hepatic liver failure. Otherwise, there's not a whole lot with it. It's kind of just, it's a very good, benign antibiotic to give. The main one is your liver failure. So again, no alcohol. I'll go over those at the end again. Next one is the aminoglycosides. This one is gentamicin. So this one's going to be used more for your serious gram-negative infections. So I kind of say you don't really know what those are, but it's kind of one case is what it's used for, so I bring it up. Basically what it is, it's going to be used for bad infections from GI surgery. The thing, as I said earlier, it has the drug interaction with aminoglycosides, with penicillin, because they both have a synergistic effect, and so when you use this with it, it can lead to just higher chances of drug toxicity, so you can kind of be aware of that. It has a very narrow therapeutic window, so drug levels will be drawn. You only know what those therapeutic windows are. You have to be aware that, like for vanco and for gentamicin, you need to draw drug levels. It's usually given IV, doesn't really absorb well orally, because again, you're giving it for an abdominal infection, so your GI tract's not working very well. So you can try to circumvent it. Things you need to be aware of with gentamicin is your main side effect is going to be, can lead to neuromuscular blockade, which I don't believe you covered neuromuscular medications. You may have, I don't know, because I'm kind of starting like this semester. But basically what neuromuscular blockade is it's going to lead to disruption in nerves sending the electrical conductions on the nerves to the muscles to have a response. So you're going to have decreased muscle response. So it's going to be important in people with myasthenia gravis or Parkinson's. You're going to see an exacerbation in their problems. You're also going to see respiratory depression from this neuromuscular blockade because your diaphragm is a muscle. People kind of forget about the diaphragm is there with breathing, but the diaphragm is what causes you to breathe. So if something's going to affect your neuromuscular function, it's going to cause you to stop breathing. So you got to be aware of your respiratory rate. On top of that, those are the main ones, but you need to also be aware of, again, autotoxicity, side effect, kidney function levels. That's pretty much it. Things to be general note, kidney function level. So things to look out for with kidney function. 1, urine output. B, any sort of edema, BUN, creatinine, and also your red blood cell levels because your kidneys secrete erythropoietin, which is used for red blood cells. Liver failure. Liver failure, LFTs, liver function tests, enzymes, things like that. You're also going to see the jaundice from the bilirubin. You're going to see darker urine because the bilirubin is going to be excreted through the kidneys. When your liver fails, your kidneys kind of pick up the slack from the liver until they get taxed, and then they end up going into failure. But you see darker urine, not from concentration, but from the excess bilirubin being excreted through the urine. And you're also going to see telltale sign is the clay-colored stools. That's because there's going to be no bilirubin in the stool, so you have that really kind of clay-looking colored stool. And then another thing with liver failure is huge risk for bleeding because your liver does all of your clotting factors. It's kind of a random time to talk about liver and kidney function, but I haven't talked about it yet, so I figured now's a good time. Alright. Next one is sulfonamides. This one is basically Bactrim. So sulfonamides is a sulfa medication. I don't know if you've had any other sulfa medications, but basically it has what's called a disulfiram reaction, which if anyone has alcohol abuse, they give them disulfiram, which if you, depending on the person, either smell or drink or imbibe alcohol, you become violently ill and you spit the alcohol up so you can't ingest any alcohol. So the same thing is it's not as potent as if you're taking disulfiram, but it still has that reaction. It's a sulfa generation. So we really need to teach them not to drink with this because they just get violently ill. Other medications don't want to teach them not to drink, but that's going to be more for liver function. This one, they take it, they can just end up getting vomiting just nonstop. Other side effects besides, of course, liver failure is going to be crystalluria. So basically what that means is it's going to cause uric acid formation in the urine, which can lead to kidney stones and pain and kidney failure. So you're going to want to have them increase their fluid intake to help them pee out the crystals before they have any complications. The other thing, it can also cause liver failure, and also women who are pregnant or lactating, because you can cause liver failure in the fetus and also in the newborn. So the Bactrim will go into the breast milk through the placental membrane into the fetus, into the baby, thus causing liver failure in them also. These also have hypersensitivity reactions to diuretics and sulfonylureas. Sulfonylureas I don't believe are covered yet. They are an oral anti-diabetic, so just kind of be aware of that. If you see something that might, right now, they don't really feel like a diuretic at you, but if there's someone's taking Bactrim and Lasix, hydrochlorothiazide, just be aware that's going to be a drug interaction. The other huge drug reaction with Bactrim, you can see something called Stevens-Johnson syndrome. Stevens-Johnson syndrome starts out as a small rash, so you might see a question of which one of these patients you want to see first. There'll be a patient taking Bactrim as a rash. Like, well, it's a rash. It's kind of, it's benign. Who cares? While in someone who's on Bactrim or someone taking a medication that causes Stevens-Johnson's, that rash is a huge side effect. It's life-threatening. It's like their most acute problem there's going to be. Because what happens with Stevens-Johnson's is that rash then gets worse. Basically what ends up happening is their skin basically starts to peel off in sheets, and huge risk for infection. They'll start bleeding and this and that. It's very hard to treat, and I believe the mortality rate's pretty high with this. So if you can kind of stop it before it progresses further, it's a good thing to get on top of. I've actually seen one patient with Stevens-Johnson's, and we had to ship him off somewhere like to a burn unit to get proper care, because he needed to be in a sterile environment because his skin literally just peels off in sheets. So rashes may not seem like a major thing, but if Stevens-Johnson's in there, that's your problem. Alright, the next one is ciprofloxacin. This one is going to be used predominantly for UTIs. UTIs are generally caused from gram-negative infections because it's usually fecal material that ends up getting in the urethra causing the UTI. So you already see something with UTIs, think gram-negative. So just kind of a random shout out there. Otherwise, Cipro's good for anthrax treatment. Check your mail for powder. Otherwise, that's a poor joke. Your major side effect with Cipro is going to be Achilles tendon rupture. So you want to teach your patient not to do any excessive forms of exercise, be it running, jogging, lifting a lot of weights with their legs, any sort of extreme things with their legs. It's predominantly more seen in children and in older adults, but anyone can do it. It's just kind of this random weird side effect of the Cipro. It just degrades the Achilles tendons, cartilage, and just literally ruptures, and they kind of fall down. So you also don't really want to give it to children because it has a higher chance of Achilles tendon rupture in the children. This also has crystal urea with it, so again, hydration is going to be key to kind of urinate out those uric acid crystals. Other thing I have, I don't know if you have it on there, I remember some of my stuff you guys don't, but I'm going to cover all of them just in case, is nitrofurantoin or macrobid. This is going to be for UTIs, pretty much UTIs only. The thing with nitrofurantoin is you got to be looking out for is your kidney functions. It's going to have huge kidney nephrotoxic side effects. It can also lead to peripheral neuropathy. Peripheral neuropathy is basically numbness, tingling in your peripheral fingers and toes. Generally, you can treat peripheral neuropathy with gabapentin. So if you ever had gabapentin in your clinicals, it's going to be predominantly used for peripheral neuropathy. Even though it is a seizure medication, you give it for peripheral neuropathy. Just throwing it out there. The other thing it can lead to is thrombocytopenia, which basically is a decrease in your platelets, so you have a higher risk for bleeding. The macrobid, the nitrofurantoin, can also be given prophylactically to women who are more prone to UTIs. Especially a lot of women can have UTIs after sexual intercourse, so you can give them the nitrofurantoin as a prophylactic after intercourse. They can take one to kind of help prevent the chance of them getting a UTI. General teaching note there. So next ones I have are going to be for tuberculosis. Few notes on tuberculosis. You'll probably see a couple questions on tuberculosis on your test. 1, airborne infection. So it's not droplet, it's airborne. So you have to have the huge N95 duckbill masks, negative pressure rooms, limit visitors, all that. You have the huge big gowns. Tuberculosis is very hard to treat, so you can use multiple medications in lower doses, kind of not get the tuberculosis resistant to them, because it is very resistant. So you got to throw a lot of different things at it, and hopefully all of them will synergistically kind of slowly degrade tuberculosis down to the point where it's no longer infected. Tuberculosis skin tests. So the tuberculosis skin test only tests if you have the tuberculosis antigen in your body. It does not tell you if you have an active tuberculosis infection. Only you were either exposed to tuberculosis at one time with the antigen, or you do have an active infection, or you've had one previously. If anyone is positive tuberculosis, they have to do a chest x-ray to look for the tuberculosis nodules in their lungs. So the tuberculosis skin test does not test positive for tuberculosis, it only tests for the antigen. Random note there. The other thing is, treatment will take a long time. You generally 6 months to a year in the hospital in negative pressure, try and get this completely treated. Random note, about 30% of the world is infected / colonized with tuberculosis. So it is a very deadly disease. A lot of people just kind of colonize with it, so they have it. It's not actively infected. They have tuberculosis nodules in their lungs. So the first drug is INH, or isoniazid. That's probably not how you pronounce it. These ones, all your medications for tuberculosis are going to lead to strong hepatotoxicity. It's going to really destroy your liver. So you're going to be treating a very bad lung infection at the same time you're slowly killing your liver. So it's going to be strongly hepatotoxic. It can also cause peripheral neuropathy, which can be reversed / prevented with pyridoxine, which I believe is a vitamin B something. I don't remember which vitamin B it is, a lot of them. But that can actually prevent, help / treat the peripheral neuropathy caused from INH. The other thing is, if you take it on an empty stomach, it can interfere, food can interfere with the absorption, and it also has a drug interaction with rifampin. Now, the other tuberculosis medication is, rifampin. So rifampin, it's kind of the same thing. Generally, this is used for, wrong thing with that. Rifampin, very huge hepatotoxicity. This one, random side effect, if you see it in any test or random whatever, it can turn every body excretion, be it saliva, tears, urine, stool, a red-orange color. Also, general note is that it can interact with HIV medications. Predominantly speaking, most people who are going to have tuberculosis outbreak are going to be something in a third world country where HIV is very prevalent, and they're going to be getting treated for that too. So you have to be aware that the rifampin is going to help treat the tuberculosis, will alter their HIV medications. Alright, let's see here, what's next? Antivirals. So the first antiviral I have is acyclovir. Acyclovir is going to be for herpes simplex 1 and 2, and CMV. CMV is cytomegalovirus. It's basically it's kind of up and coming hard virus to treat. Acyclovir is going to be drug of choice for herpes, as I kind of mentioned, and also chickenpox, varicella. So when you're talking about herpes, it's going to be a lot of education along with it. That is, herpes simplex 1 and 2 are generally the same viral infection. It's just they are colonized in different areas, either orally or genital region. So you have to educate your patients, and they have, like the cold sores, is not to have any sort of sexual intercourse with that region, so no oral sex at all, because you can transmit from 1 to 2. You can spread it to genital region. So you can also spread herpes without any lesions forming. So you can have a localized infection of herpes, but none of those signs and symptoms. So you always have to kind of be aware of that. The acyclovir will decrease the flare-ups of the herpes, but herpes is still always colonized in your body orally or generally. So there's going to be a lot of teaching along with this. And also, it can eventually lead to sterility, especially in males. And then you're going to want to wait for sexual intercourse until the lesions have healed. You don't want to remove the crust, kind of let it run its course, and then wait a little while because you still have like a secondary infection of the herpes kind of lingering. So you always have to wait. It's a lot of education with this. Otherwise, acyclovir is going to lead to a lot of malaise, tiredness, dizziness, confusion, so neurological signs and symptoms. It can also lead to kidney failure. That's pretty much it. So next one is antiviral. All your antivirals usually have VIR at the end, vir. Not all of them are antivirals, but it's a good way to kind of zoom in and say, yes, this is how you can treat a viral infection. So that's what it is. So ganciclovir is going to be used mainly for CMU cytomegalovirus. It can lead to myelosuppression, or basically it's going to lead to granulocytopenia and thrombocytopenia. What that means is going to be a decrease in your white blood cell counts and your platelets. So you're going to have increased chance of secondary infections and a risk for bleeding. Odds are it's probably going to cause the thrombocytopenia, so you're going to have to be aware of that. You're going to give platelet infusions or just assess signs of bleeding. There's going to be anemia, pale, tired, dark stools, because you can see a lot of thrombocytopenia, risk for bleeding in the GI tract. Upper GI bleed is going to be black stools. Lower GI bleed is going to be more tarry stools. So if you kind of see a question about any sort of GI bleed, it's going to be the blacker the stool, the higher up the GI tract it is, because that basically what that means is the iron in the blood has been oxidized through the GI tract, thus turning it a black color. Random note again, I kind of throw a lot of those out. Anyways, back to ganciclovir. It is highly tetragenic, which means it's going to be a huge risk for pregnancy. It'll end pregnancies, it'll prevent you from getting pregnant, and this is for, I believe, both partners for at least 90 days should avoid sexual intercourse with someone who's pregnant or trying to become pregnant. Alright, the next one is going to be an antiprotozoal, which is not, you probably won't use it for an actual protozoal infection or amoeba, but it's Flagyl. It's also a very good, just general anti-infective, antibacterial. So Flagyl, again, has that disulfide reaction, so that's going to cause the reaction with alcohol, so it's going to be aware of any sort of alcohol use. It can lead to numbing, tingling, like the peripheral neuropathy. If that begins, you have to stop it right away because it's not reversible. You also do not want to use it within the first month of pregnancy. Theoretically, don't use it at all through pregnancy because it's tetragenic, so it can cause spontaneous abortions. So you don't want to use it for that. Flagyl can generally be used more as a prophylactic, like cefepime, for your anaerobic gram-negative, maybe not gram-negative, but at least anaerobic infections. General note. Okay. I feel like here it is. So the next one is the antifungal medication. Antifungal, or ampicillin, fungizone, generally, all antifungals end in azole, A-Z-O-L-E, yeah. But not all things that end in azole are antifungal. It's kind of like all rectangles are squares, but not all squares are rectangles. Or however that dynamic works, I can't remember. But knowing that azole, odds are it's going to be an antifungal. So it's going to be only for systemic fungal infections, not so much your topical treatments for athlete's foot or a yeast infection. You use nystatin for that. but next stand is an azole. But anywho, Amphotericin B is your main antifungal. It's going to have a huge side effect, kind of coded as shake and bake, which is going to be fever, chills, rigors, and headache. So basically what you're going to want to do is give it slowly to help decrease that, but before you give it, you're going to generally pre-treat with some sort of fluid bolus of saline, generally acetaminophen, Tylenol for the fever, steroid, or Meridian or Demerol, and those are going to be before it can help counteract the shaking. Now, you're giving the liter bolus of saline because you're basically going to increase their blood volume, dilute their blood volume out, and then give the medication, so it won't be as concentrated in the blood. The other thing to be aware of, it can only be given with D5W, dextrose 5% in water. You are giving a saline bolus or some sort of bolus theoretically beforehand, unless they're already fluid overloaded. Then you need to re-flush that line with D5W before you hang that medication, because it will have an interaction with saline. It is extremely hard in the kidneys, can lead to permanent kidney damage, so you gotta be assessed kidney levels. It can also lead to hepatotoxicity, so be aware of your liver function. It can lead to decreased synthroid synthesis, which is your Cushing's syndrome. And also, that's it. So maybe Amphotericin B, sorry, I can't talk, it's getting late. Yeah, it's going to be your shake and bake, fevers, chills, rigors, pre-treat, saline, Tylenol, steroid, Demerol, and then only give it with D5W. That's the main thing. You can also lead to hypomagnesemia and hypokalemia. So on the post I kind of missed earlier on lab levels, generally speaking, your potassium level is going to be 3.5 to 5.1, I think ATI is, and then magnesium is like 1.5 to 2.1. So when it comes to your lab levels, ATI is looking to know you know what the max or minimum is, and they will throw a question at you that there may only be a slight variation in the level. So like potassium would be like 5.1. Well, it would be like 5.2 or 5.3. So they really want you to be aware of that. Otherwise, that's all I have for anti-infectives. But as I said before, I will give you a quick list of things that can cause random problems. So, medications you don't want to have alcohol with, that is cephalosporins, macrolides, Flagyl, INH, and Bactrim. Medications that can cause ototoxicity, vancomycin, macrolides again, and aminoglycosides. And the only ones that you need to worry about any sort of GERD or esophageal erosion, that's going to be tetracycline. Have them set up for 30 minutes. That's all I got. So good luck. If you have any questions, let me know.